A hospital algorithm was quietly deciding which patients deserved extra medical help, and it was getting the answer wrong for millions of people in the exact same direction for years before anyone caught it. Nobody programmed it to be unfair on purpose. Nobody meant any harm at all. And that's exactly what makes this story about AI and healthcare so unsettling. Today, we're walking through 5 real, documented risks hiding underneath the AI healthcare boom, and just the stuff that doesn't make it into the shiny press releases. Think of it as a journey from the risk you've maybe already heard whispers about, but to the one that's honestly the easiest for any of us to fall into ourselves. Think about a hiring manager who only ever promotes people who look like the last 10 people promoted. Even if that manager isn't personally prejudiced, the pattern they're copying already has bias baked into it. And copying it faithfully just repeats the problem. Here's the real, verified case. Researchers published a study in the journal Science in 2019 examining a widely used commercial algorithm that hospitals across the country relied on to decide which patients needed extra care management. At the same risk score the algorithm assigned, Black patients turned out to be considerably sicker than white patients. The reason wasn't malice, it was a design shortcut. The algorithm used healthcare costs as a stand-in for how someone actually was, but because the healthcare system historically spends less money from treating Black patients for the same level of illness, the algorithm learned to underestimate their needs. Fixing that one flawed assumption would have nearly doubled the number of Black patients flagged for extra help. Here's what this means for you. An algorithm doesn't have to be built by someone with bad intentions. To produce a biased result, it just has to learn from a healthcare system that already has inequality inside its data. If you're a patient, especially from a historically underserved community, it's fair to ask whether a tool is recommending your care has ever been checked for exactly this kind of gap. Picture a very confident friend who tells you a detailed, specific story about something that never actually happened and says it with total conviction. No hesitation, no hedging. You'd have no way to know it was made up just by how sure they sounded. That's essentially what researchers at Stanford found when they tested AI models used for medical imaging. They discovered that some AI tools can produce detailed, plausible-sounding diagnoses on X-rays. They never actually analyzed at all a pattern, an AI mirage. In one extreme case, a model scored well on a chest X-ray benchmark without ever being shown a real image to begin with. The output looked like careful medical reasoning. It wasn't grounded in anything real. Here's what this means for you. Confidence is not the same thing as accuracy, whether it's coming from a person or a machine, and that's especially true for AI. If a doctor mentions that an AI flagged something on your scan, a fair follow-up question is simply whether that finding was double-checked by a human who actually looked at the image themselves. And then, think about a driver's ed student who aces every test on a quiet, empty practice course,
and then panics the first time a real car cuts them off in actual traffic. Practice conditions and the real world are not the same test. Here's a documented, real example, the epic sepsis model. A tool built into one of the most widely used hospital record systems in the country, but was designed to flag patients at risk of a life-threatening condition called sepsis. When researchers at the University of Michigan tested it against real hospital data and published their findings in JAMA Internal Medicine, they found the model missed roughly 2 out of every 3 actual sepsis cases, all while generating so many alerts that clinicians reportedly started tuning them out entirely. At a problem researchers call alert fatigue. Here's what this means for you. A tool performing beautifully in a company's own internal testing doesn't guarantee it performs the same way once it's actually running in a real, busy hospital, on real patients, in real time. That's not a reason to distrust every AI tool. It's a reason to ask whether a tool has been independently checked after it went live, not just before. Imagine a car with a very advanced cruise control system gets into an accident. Is that the driver's fault, the car company's fault, or the software engineer's fault? That question doesn't have a clean, agreed-upon answer yet, and medicine is wrestling with the exact same uncertainty. Regulators are actively trying to catch up to this problem right now. The FDA has started requiring what are called predetermined change control plans for certain AI medical devices, essentially a pre-approved roadmap for how an AI tool is allowed to update itself over time. Since these tools can keep learning and changing after they're already in hospitals. As of last year, only about 1 in 10 newly cleared AI devices included one of these plans, meaning the oversight framework for most tools is still catching up to how often the underlying software actually changes. Here's what this means for you. When something goes wrong with a diagnosis today, there's a well-established process for holding a doctor accountable. The rules for exactly who's accountable when an AI tool contributed first to that mistake are still being written in real time right now. That's an uncomfortable gap. And it's honest to say so rather than pretend it's already settled. Picture trusting your GPS completely, even as it tells you to turn directly into a lake. Most of us catch that because we're still paying attention to the actual road. The moment you stop paying attention and just follow the voice, the machine's mistake becomes your mistake. Researchers studying exactly this behavior among doctors found something called automation bias. And the numbers are striking. In one study of AI-assisted diagnostic decision-making, clinicians were about 10 times more likely to reach the correct decision when the AI's suggestion happened to be right, but their accuracy dropped when the AI's suggestion was wrong. Meaning some doctors followed flawed AI advice right past their own better judgment. This isn't a story about bad doctors. It's a story about how naturally any of us start leaning on a confident-sounding tool, human or software, until we stop double-checking it at all. Here's what this means for you. The safest version of AI in your healthcare isn't one where the doctor blindly trusts it, and it isn't one where they ignore it either. It's one where they're still actively thinking alongside it. If you're ever curious, it's completely reasonable to ask your doctor what led them to agree or disagree with something an AI tool suggested. A doctor who can answer that is still in the driver's seat. So to recap, first, AI can quietly inherit the same inequalities baked into the data it's trained on. Second, AI can sound completely confident while being completely wrong. Third, a tool that looks great in testing can perform much worse once it's actually deployed in a real hospital. Fourth, nobody has fully agreed yet on who's responsible when an AI tool contributes to a medical mistake. And fifth, the biggest everyday risk isn't the AI itself, it's humans trusting it a little too blindly. If you want to see the flip side of this story, the real safeguards, hospitals and regulators are building right now to catch these exact problems. That's exactly what we're covering next. So go ahead and subscribe so you don't miss it.